Good morning. Welcome to our webinar. The title of our webinar this morning is Financial Literacy, Affording Hepatitis C Treatment. My name is Ken O'Riordan, and I'm talking on behalf of the American Liver Foundation. As you know, hepatitis C affects between 3.2 and 5.2 million people in the United States. About 80% of these patients go on to develop chronic infection from this. 20% of these patients will develop complications from hepatitis C, such as cirrhosis, liver cancer, often requiring intensive medical therapies, medications, hospitalization, and possibly liver transplantation. 15,000 people die annually from hepatitis C infection in the United States. The World Health Organization has talked about a global call for the elimination of hepatitis C. Their vision is a world where viral hepatitis transmission is stopped and everyone has access to safe, affordable, and effective treatment and care. Their 2020 target is that 3 million patients with hepatitis C will have been treated. This is feasible by scaling up 6 key interventions to high coverage. Hepatitis B vaccination, including vaccination at birth, safe injection practices and the use of safe blood products, harm reduction for people who inject drugs, safer sex, including condom promotion, treatment of hepatitis B, and cure of hepatitis C. Their 2030 targets are that 90% of patients with hepatitis C will be diagnosed, 80% will be treated, and there will be a 65% reduction in mortality from hepatitis C. When we look at the burden of advanced liver disease over the next couple of decades, we'll see that liver disease from hepatitis C was much more prominent over the last 20 or 30 years, with increased frequency and severity, and certainly the risk of developing cirrhosis from 1990, when there was a risk of 5% chance of cirrhosis. This has been projected in year 2020 that 37% of patients with hepatitis C infection will have evidence of underlying cirrhosis. Certainly, treating hepatitis C has been shown to reduce healthcare costs in the United States. We'll see here in this graph that the difference between treated and untreated patients, both with non-cirrhotic liver disease, compensated cirrhosis, as well as end-stage liver disease, treatment definitely is beneficial in reducing both total costs of healthcare, medical costs in general, and also costs related to hepatitis C infection. When patients eradicate the virus or are cured of hepatitis C, the sustained virological response rate has been associated with various different improved qualities of life. This is a study from a real-world clinic population where treatment and eradication of the virus was associated with improvement in bodily pain, improvement in general health, physical functioning, as well as emotional and social functioning. There was also an improvement in mental summary scores and physical summary scores with eradication of the virus. Certainly, treating hepatitis C may have multiple other benefits. Hepatitis C cure definitely reduces the incidence of type 2 diabetes mellitus. Treating patients with hepatitis C who also have diabetes mellitus does decrease the frequency of development of end-stage renal insufficiency, as shown in this graph on the right. There is also improved renal and cardiovascular outcomes. With hepatitis C, what happens if we do nothing? Well, a couple of studies, both from England as well as Sweden, have shown that over the next 20 years, there will be a significant increase in the development of decompensated cirrhosis, hepatocellular carcinoma, as well as the need for liver transplantation. Treatment of hepatitis C can be done at various different points in the disease course. treating patients early in the disease course can help prevent progression of liver disease. In this study, progression was seen from patients with mild liver disease initially to more advanced liver disease in 15% of patients over a period of 20 years. Treatment did decrease this progression of liver disease. If we treat patients with cirrhosis, there is certainly a rapid reduction in mortality, but we are forever playing catch-up with the disease. People with cirrhosis still remain at high risk of hepatocellular carcinoma and must remain under surveillance for this. These patients, however, are the most expensive to treat. So how do you motivate testing without offering potentials for patients to undergo therapy? So who should be treated for hepatitis C infection? Well, the short answer is everybody. The recommendations from the American Association for the Study of Liver Disease and the Infectious Disease Society of America are that the panel continues to recommend treatment for all patients with chronic hepatitis C virus infection, except those with short life expectancies who cannot be remediated by treating hepatitis C by transplantation or by other directed therapy. When we look in the United States at gaps in hepatitis C treatment and evaluation, we notice on this graph here that of the patients who are initially diagnosed as being hepatitis C antibody positive, only a small percentage of those patients subsequently undergo testing to confirm active viremia. An even smaller number undergo therapy for hepatitis C. However, once patients undergo therapy for hepatitis C with the newer therapies, most patients are able to complete therapy, and a high percentage of patients achieve a sustained virological response. All persons with current active hepatitis C infection should be linked to a practitioner who is prepared to provide comprehensive management. Improvement in the identification of hepatitis C infection and advances in treatment will have limited impact on hepatitis C morbidity or mortality without concomitant improvement in linkage to care. And this is extremely important. Certainly, care of patients with hepatitis C is extremely complicated and involves multiple different people in the healthcare environment. There typically is a provider for hepatitis C who may be an RN, a nurse practitioner or physician. There is usually an administrative coordinator in the office, a pharmacist who is involved in coordinating care for medications, a case manager, somebody who is involved in assessing fibrosis, which could be a laboratory technician or a technician involved in a FibroScan measurement or an MRI of the liver to assess fibrosis. Frequently, these patients do have a mental health provider involved in their care, and often addiction specialists are involved in patients who continue to use intravenous drugs. With decompensated liver disease, patients are frequently referred to a hepatologist or liver transplant center. So what are the benefits of achieving a sustained virological response? Well, the goal of hepatitis C treatment is a cure of hepatitis C. This is associated with improved clinical outcomes, which can either be hepatic, such as a decrease in the incidence of cirrhosis, liver decompensation, decreased incidence of hepatocellular carcinoma, and decreased need for liver transplantation. There also is an improved quality of life, a decrease in frequency of malignancy, diabetes, coronary disease, renal disease, as well as improvement in neurocognitive disorders. But also curing hepatitis C, most importantly, does result in decreased transmission of the infection. The therapies we have for hepatitis C have evolved significantly over the last 20 years. Back in the 1990s, we were treating patients with standard interferon therapy with its various different side effects, and this was very difficult for patients to take, and typically 10 to 15% of patients eradicated the virus with that treatment. During the late 1990s and mid-2000s, the addition of other pegylated or long-acting interferons improved their sustained virological response rate, and over the last 5 years, the treatment for hepatitis C has exploded rapidly with the addition of oral medications, which initially have been given with interferon, with sustained virological response rates of 70%, and most recently, the combination of all oral antiviral therapies for hepatitis C with minimal side effects have been associated with sustained virological response rates of over 95% if patients treated. So where does hepatitis C treatment stand now? Well, interferon is gone for most patients in the United States. Ribavirin is still used in a small percentage of patients, and sustained virological response rate is over 95% in patients who are treated with newer medications. Certain patient groups in the past have been very difficult to treat, such as black race, patients who are co-infected with HIV, as well as patients with underlying cirrhosis. But these patients have response rates now the same as other patients who are treated. Patients with genotype 3 hepatitis C still remain challenging to treat, especially when they have cirrhosis or have failed other antiviral therapies. Typically, when patients eradicate the virus and are clear of the virus 12 weeks after completing therapy, which is defined as sustained virological response, this is now considered a cure. And late relapse beyond this time point is extremely rare. But obviously the cost and access issues are what we shall talk about next. So when we look at treatment for hepatitis C, this is a study from Australia looking at the number of patients who were treated over the last 20 years with hepatitis C, and we'll see in green over the last couple of years there's been a marked explosion in the number of patients who are now undergoing antiviral therapy for hepatitis C, which is non-interferon based. When patients undergo approval for hepatitis C therapy, there are various different hurdles that need to be crossed. The medication needs to be prescribed by either an infectious disease doctor, gastroenterologist, or liver specialist. Documentation of viral load needs to be performed within 3 months of starting therapy. There needs to be some estimate of fibrosis, either by blood testing or by scans. We need measurement of a hepatitis C genotype, and patients need to undergo a measurement of viral loads during and after completion of therapy. So what are the current all oral regimens available for hepatitis C infection? I'm listing in this graph here the multiple medications that we now have available. Razopravir with elbesvir has been approved for genotypes 1 and 4. Bitasvir with paritaprevir and ritonavir is approved for genotype 4. Bitasvir, paritaprevir, ritonavir, and dasabuvir is approved for genotype 1. Sofosbuvir and decladisvir is approved for genotypes 1 and 3. Sofosbuvir and ledipasvir is approved for genotypes 1, 4, 5, and 6. Cimeprevir and sofosbuvir is approved for genotype 1. And sofosbuvir with velpatasvir is approved for all genotypes 1 through 6. It is important to test patients prior to starting antiviral therapy for evidence of prior immunity to hepatitis B and to look for any evidence of hepatitis B viremia, and if this is present, to treat this either before or concomitant with hepatitis C therapy. So what is the treatment cost? Well, there are various different things that need to be considered. There is the wholesale acquisition cost, which is relatively transparent and static, but is relevant in relative terms only. What the payers actually pay is probably most relevant, but this is quite opaque, and the costs do seem to be coming down. There are various deals that have been brokered with specialty pharmacies, discounts available for large payers such as the VA, and government negotiated plans in various countries. The production cost of these medications, however, is not officially known, but estimates suggest that it is quite low, at a cost of between $100 and $300 per course in different countries. Looking at the 2015 prevalence, treatment rates, and treatment patients in various different countries, we'll see the prevalence rates in both the United States, various countries in Europe, as well as in Japan, and the treatment rates in these countries. In the United States, the treatment rate of patients with hepatitis C was 8%, 12% in Spain, United Kingdom only 3%, and interestingly in Italy the treatment rate is only 2%, although the prevalence rate is quite high at 3.5%. In the United States, a total of 237,000 patients were treated, of which 118,000 of those were Medicare patients. When we look at drug companies and reimbursement, the pharmaceutical companies determine the wholesale acquisition cost. Pharmacy benefit managers can negotiate contracts with pharmaceutical companies on behalf of health insurance companies. The insurance companies determine formulary placement, such as private insurance companies, Medicaid, as well as Medicare. Medicare covers hepatitis C drugs through Part D benefits and cannot negotiate drug prices. Specialty pharmacies do get dispensing fees and may receive incentives for ensuring patient compliance. And patient costs are typically determined by their pharmacy plan. When looking at government funding, a higher proportion of treatment-eligible patients will be entering the age of Medicare, Medicaid, and the VA system over the next 10 to 15 years. Hepatitis C is very prevalent in what's termed demarginalized patients, such as homeless patients, where the rate is between 22 and 53%, intravenous drug users at a rate of 58%, severely mentally ill at a rate of 19%, and incarcerated patients at a rate of 23 to 41%. Should these patients not be allowed to have access to hepatitis C medications? Should we be rationing therapy for certain patients with hepatitis C? This brings up several important issues, such as what is the value of a cure, what is the worth of a human life, and whose life is worth saving. Medicaid is a series of multiple insurance plans with fee-for-service and managed care options. Most plans negotiate pharmaceutical rebates. Differences in negotiated contracts mean different access to medications in different states. Typically, Medicaid receives the lowest pricing of hepatitis C medications with a minimum drug rebate of 23%. One main issue with Medicaid is coverage restrictions and the rationing of therapy for hepatitis C. It has been recommended that patients undergo a test and treat approach. However, this may not be a reasonable option if treatment is subsequently not an option for these patients. Many decisions have been based on a report in 2015 from the Oregon Health and Science University, which was primarily a report looked at cost-saving measures. The restrictions to hepatitis C treatment can now be challenged in court, and this has been proposed in Illinois as well as other states where this is in progress. And this report from the Oregon Health and Science University has been challenged by many practicing clinicians and also by the American Association for the Study of Liver Disease. The American Association of Study of Liver Disease has commented that unfortunately payers across America are denying hepatitis C treatment when a doctor has prescribed it for their patient. Patients who received advice from their doctor to take the newest treatment should not be denied. Criticism of treatment recommendations results not from the recommendations themselves, but from the financial burden that treatment places on patients, insurers, and the government. What about the requirement for sobriety? Variable periods of abstinence have been requested, although this has been based on no data prior to starting patients on hepatitis C treatment. This requirement is not needed in other disease states for medication approval. Do we restrict treatments based on sobriety for hypertension, diabetes, cancer, or heart disease, even though these may be more expensive as lifelong therapy is usually needed, with no definitive cure available in some of these diseases? Hepatitis C treatment, however, is finite treatment course and a cure in most patients with prevention of disease progression, transmission, and significant downstream cost savings. This graph looks at the Medicaid reimbursement criteria for newly acting direct antiviral agents based on drug and alcohol abstinence. As you'll see in these graphs, various periods of abstinence are required in certain states prior to starting hepatitis C therapy. Some states have unknown restrictions and some states have variable restrictions. In Illinois, we both have unknown restrictions as well as varied restrictions. The period of abstinence varies from no restrictions to greater than 6 to 12 months of abstinence from alcohol and drug use. When we look at treating patients with hepatitis C, certain states require documentation of significant fibrosis or cirrhosis prior to approving antiviral therapy for hepatitis C, and this is in contradistinction to the American Association of Study of Liver Disease recommendations. Some states approve hepatitis C therapy for all degrees of fibrosis and hepatitis C. Other states are more restrictive with approving therapy only for patients with the most advanced disease such as F3 and F4. And these are graphs of the Medicaid disease requirements in different states in the United States. Certainly hepatitis C transmission does continue on patients who continue to use intravenous drugs, and we see that this may stay stable in many states. In some states there is a decrease in transmission, and in other states there has been noted to be an increase in transmission after eradication of hepatitis C. We know that in certain subgroups of patients there is hepatitis C reinfection after initial eradication of the virus. This may be at a rate of approximately 10% in incarcerated patients and patients who continue to use intravenous drugs, and the rate may increase up to 15% in patients who are infected with both hepatitis C and HIV. So what about the cost effectiveness of treatments? What's important is how much will we spend on a new medication, and that looks at the cost of the medication and the lifetime cost versus the cost of the disease. What's important is what is the accrued benefit from a new intervention, and this is frequently measured in quality-adjusted life years. And how much is society willing to pay to gain one additional quality-adjusted life year? And typically in the United States, this is at a cost of $50,000 to $100,000 per year, which is considered acceptable. In regards to affordability, does the payer have enough resources in its budget to pay for the medication for all who need it in a given year? With more and more people diagnosed with hepatitis C and newer treatments available, this cost is significant. The perspective on cost is that the insurers only consider their own revenues and expenses and not those of the patients. Insurance companies often use a short-term perspective, such as a 1 to 5 year perspective, and do not look at long-term consequences in following patients over a period of 20 to 30 years. What's important is the willingness to pay and the real-world bottom line. These insurance companies have multiple diseases that need treatments, multiple patients who are affected, multiple interventions that are needed, and large expenses. This slide shows the difference in cost of various different medications which are now approved for hepatitis C in different areas of the world. So pricing, sofosbuvir 1 month of therapy costs $16,000 in Romania and $15 in Pakistan. If we treat all patients with hepatitis C, this can take up a significant amount of a nation's healthcare budget. In the Netherlands, this comprises 10.5% of the healthcare budget and 190.5% of the healthcare budget in Poland. The pricing is unmanageable in many countries, causing us to look at other options such as generic production of medications, leverage with pricing of medications, strategic procurement of medications, as well as competitive bidding. There is no single solution to pricing, and each country has its own unique challenges. Sofosbuvir is the most lucrative medication launch on record. In 2014, there was $12.4 billion in sales of this medication. The cost to treat 3 million people with hepatitis C in the United States would be a cost of greater than $250 billion. In 2011, the total U.S. drug spending on all medical conditions was $263 billion. The drug price is unrelated to any reasonable return on investment or cost of production. When a competitor to sofosbuvir was released, called Viekira-Pak, interestingly this was released at a price roughly the same as sofosbuvir. So what are the daily wholesale acquisition costs of direct-acting antiviral agents? Well, if we look at the trade names of some of these medications that are approved for hepatitis C, Declinza costs $750 per day, Zepatir costs $650 per day, Harvoni costs $1,125 per day, Technibee costs $912 per day, Viekira-Pak $992 per day, Olysio $790 per day, Sovaldi $1,000 per day, and Epclusa $890 per day. So what is the estimated cost of treatment of genotype 1? These are numbers looking at between 12 and 24 weeks of therapy with various different combinations for hepatitis C infection. Obviously, shorter durations of therapy are also available. Typically, the cost of 12 weeks of therapy in the United States for hepatitis C genotype 1 with decladisvir and sofosbuvir is $147,000. With elbasvir and grazoprevir, the cost is $54,000. Ledipasvir and sofosbuvir is $94,500. Sofosbuvir and cimeprevir is $150,000. Ombitazvir, Patapravir, Ritonavir, and Dasabvir is $168,000 for 24 weeks, and half of that for a 12-week course of therapy. And as you'll see, the costs of therapy are significant. In 2015, the net manufacturer costs of 8 weeks of Harvoni hepatitis C treatment was looked at both in the United States as well as in Japan and Europe. This was published by the Institute for Health Informatics. The average price in the United States for 8 weeks of shorter course Harvoni therapy is $52,000. In Europe, the United States is $50,000, and in Japan, $55,000. So what are the estimated total net expenditures on treated patients in US dollars? This was looked at in 2015, and this is looked at US dollars in billions. We already know the costs of these therapies. When we looked at the number of patients who were treated in the United States, there were 236,000 patients treated in 2015. Of those, Medicare patients comprised 118,000. In Japan, 119,000 patients were treated, and in the top 5 European countries, 158,000 patients were treated. The total net spending on treated patients in the United States in 2015 was $10.9 billion. That included the Medicare patients. In Japan, the total net spending was $5.9 billion, and in the top 5 EU countries, $7.7 billion. So what is the wholesale and estimated production cost for a 12-week course of antiviral therapy for hepatitis C genotype 1? With decladisvir, the wholesale acquisition cost is $63,000. The estimated production cost is between $10 and $30. Cimeprevir, the wholesale acquisition cost $66,000, and the estimated production production cost between $130 and $270. Sofosbuvir, the wholesale acquisition cost, $84,000, and the estimated production cost between $66 and $136. What is the cost of other genotype hepatitis C infections? When we look at the cost of both hepatitis C genotype and hepatitis C genotype 2 and 3 infections, Decladisvir and Sofosbuvir for 12 weeks is $147,000. Sofosbuvir and Ribavirin for 12 weeks is $295,000. Sofosbuvir with Ribavirin and pegylated interferon for shorter duration is $97,000. A combination of Sofosbuvir and Valpadosvir for 12 weeks is $80,000. So if patients are denied coverage for hepatitis C, there are certain processes that you can go through. There can be an appeal, a peer-to-peer appeal. This may request reviewer by a hepatologist. This typically is most useful when patients meet criteria for treatment for hepatitis C and the denial was considered inappropriate. An internal appeal can be looked at. If this is marked urgent, you may receive a determination from the insurance company within 72 hours. And this requires some forms to be filled out, and these are available both on manufacturer websites as well as through your pharmacist. You can do an external appeal, which typically is a longer turnaround time. This usually requires a specific request form, and you may resubmit the same documentation if no new information is available. Alternatively, you can approach a state fair hearing. A letter from the patient is requested, and then a hearing with the state judge is arranged. In Illinois, contact is by mail only, and frequently there is a several-month delay in hearing the individual case. What's very important, obviously, is patient advocacy, and patients need to interact with their local physicians in regards to approval of hepatitis C therapies. Communication with your local state representative is very important. Dealing with the VA system may help in patients who are able to avail of this, and also patients with hepatitis C can look at various other programs that have been present in the management of patients with HIV when they have been trying to obtain medications which have been extremely expensive in the past. So in conclusion, hepatitis C is curable in over 75% of patients with the presently available newer antiviral therapies. All infected patients with hepatitis C are candidates for antiviral therapies. However, cost issues and access to medications remain a major concern for both patients as well as healthcare providers. Thank you very much.